thyroid going down into your trachea into the bronchuses, then you got two lungs, right lung, left lung, you got your diaphragm, it's important. So like at the cellular level, you have your tissue, your epithelium, your basal membrane of the respiratory tract, and then your right lung having three lobes, and your left lung having two lobes, and which lobes are the largest? Lower lobes are the largest because they take up the majority of your back. Um, So that's anatomy stuff. So you got cartilage present to the level of proximal bronchioles, and then you got respiratory acini, which are beyond the terminal bronchioles, and here's where we have gas exchange. You got elastic tension and alveolar walls to keep the distal air spaces open, because when we breathe under a negative pressure system. And here's like the breakdown, like the bronchus, and then the terminal bronchus, and then the bronchiole, all the way down to the alveoli. The alveoli is located in the lungs, and that's where oxygen exchange occurs, one cell at a time. Then you have your capillary endothelium and your alveolar endothelium, and then here you have cells called pneumocytes. That's going to be responsible for O2 and CO2 exchange. Then there's a substance there called surfactant that's going to allow for lubrication there. And if you have impairments in your surfactant, you go into respiratory distress, whether it be adult or acute, depends on your age, right? So acute respiratory distress is going to be like children born prematurely, whereas adult respiratory distress is going to be adults that have severe pneumonia that affects their surfactant and they have similar symptoms. There's a surfactant of utmost importance. If a child is born before 22 weeks, well, they're not really a child because they're not viable, because they don't have surfactant. So after 22 weeks is when a fetus becomes viable, because that's when surfactant is produced. If a child's ever born prematurely, they give them betamethasone, it's a steroid, and that'll help produce more surfactant. That's like, it seems like premature, like 38, like 35 weeks or so, 36 weeks, they get betamethasone. Interstitial tissues, you got elastic fibers, collagen, mast cells, which those are important. And smooth muscle cells, and you have your alveolar macrophages. We talked about that stuff too. So you get pneumonia, infection, all that stuff that we talked about last exam, that stuff's going to be there also. And that surfactant is going to really be lubrication and decrease surface tension between the two media, gaseous and aqueous media, and allow better O2 CO2 exchange. You got your basal membrane again, right? You know what that is now. You have your ciliated cells at the alveoli, what we're seeing. So you got upper airway and lower airway. You've heard the term like upper respiratory infection. What is that exactly? Well, it's the border of the upper airway. That's usually at the right about the so medically it should be like after like the main bronchuses, but anatomically they use different things. But an upper respiratory infection is like bronchitis. It's like cough or cold and all that stuff, but it's not affecting your lungs. Like lungs is lower airway. Like if you have your lungs that are affected, that's pneumonia. Like that's a lower airway disease. A lot of people here have like chronic bronchitis, right? We talked about that stuff. And bronchitis is weird because like if any of you guys get bronchitis, we're calling it acute bronchitis, probably from like a cold or something. Like that's an upper respiratory effect. That's a URI. But like chronic bronchitis, which hallmark is copious sputum production, 3 months to years, like we're approaching more the lower airways at that point. So it's kind of not exactly what I said, it's not the anatomy, but just for you to understand, because everyone tosses around bronchitis in the community, like, oh yeah, bronchitis. Like, you know, like what is that really? We're just talking about irritation of your airways, itis of the bronchus, right? All that stuff. So nasopharynx, definitely upper airway. We'll agree on that. That's going to be nasal hair, turbinates, mucociliary apparatus. You can have an IgA disease, Cartagena syndrome, situs inversus. You guys know situs inversus? Yeah, what's the opposite?
Obstructions.
Yeah. So instead of your heart being on your left, it's on your right. It's rare. The chronic sinusitis, bronchiectasis. Oropharynx is going to be salivary, mouthful, local complement. Now, this is the respiratory tract. We're talking about diseases yet. Lower airway, you got trachea. They can have your cough there. Why do you cough? Yeah, why?
Something irritating.
Yeah, something stimulating, something irritates that. What irritates and triggers a cough? Could be fluid, could be mucus, could be saliva, could be food, could be allergens, right? A bunch of things that stick on the back of your throat. And then sharp ankle branches there. So we got ventilation and respiration, or ventilation and perfusion, or V and Q. Right? You've heard of V and Q. So ventilation is the movement of air in and out of the lungs. The principle of ventilation is blowing off CO2. CO2 is a acid, right? So CO2 turns into HCO3, which is an acid. Yes, we all get that. All right. So respiration is the process of exchanging gas between alveolar structure and blood. So you can cross out respiration, you could, and write oxygenation. It is the process of exchanging gas between alveolar structure and blood. Ventilation facilitates the process of respiration. Without ventilation, respiration cannot occur. So what happens when we take a breathe? Inhalation. During inhalation, the diaphragm is contracted, pulling down the ribs, lungs to increase the volume within the lungs, right? The negative pressure system. Your diaphragm is fully engaged, then your lungs are filled. And then when it relaxes, your exhale. Now, exhalation is like a passive thing. During exhalation, your diaphragm relaxes and moves upward to the chest cavity. Your intercostal muscles between the ribs also relax and reduce the space in the chest cavity. Expiration is a passive process and normally requires no effort. Which portion of the respiratory cycle is longer, inspiration or expiration?
Expiration.
Expiration, right? It's usually 1 to 3. 1 second in. It takes longer for that air to go. It's passive. Another way to remember that expiration is passive is when you see someone die, like in a movie, what's the last thing they do? Stop. Yeah, that's expiration because it's passive. You don't have to do anything. So inhalation requires effort, exhalation does not. Oxygenation is the process of oxygen diffusing passively from the alveoli to the pulmonary capillary. It binds the hemoglobin and red cells and dissolves the plasma to get perfused downstream. Oxygen delivery is the rate of oxygen transport from the lungs to the peripheral tissues. Oxygen consumption is the rate at which oxygen is removed from the blood by use of tissues. So states where someone is going to have high amounts of oxygen consumption are going to be states where you have hyperdynamic states, they call it. What is hyperdynamic states? That's going to be sepsis, right? Severe infection, situations where maybe they're getting surgery, maybe they're getting intervened on. These are high oxygen requiring states. Or what other diseases where oxygen delivery can be impaired? Sure. You can have issues with your vessels. You can have it. This is the rate of oxygen transport from the lungs to the peripheral tissues. But in between that is the red cell. So if the red cell cannot get to these guys to get oxygen exchange, well, then that's a problem with oxygen delivery. So pneumonia or issues where affecting the lungs can be a problem with oxygen delivery. And that in turn, your consumption is going to be ramped up also because you got pneumonia and it's like a double whammy, right? So how do you fix the oxygen consumption problem? Well, you just increase the oxygen. How do you increase the oxygen? You got to treat the pneumonia. So it's kind of, they're tied together, but still separate concepts because you can have only one that's affecting. Just you can have normal consumption, but impaired delivery. That's also a thing. So who is responsible for breathing? Well, the brain, central nervous system, brain, spinal cord, neuromuscular conduction. Then you got your downstream stuff, your upper airway, thorax, pleura, cardiovascular system, so on and so forth. So to have a breathing problem, you can have an issue with any one of these, right? It doesn't have to be, oh, let's say someone's intubated, right? You're assuming they can't breathe on their own. Well, that assumption would be correct. Then would it not be assumed that there's something wrong with their lungs on a machine? The answer is, yeah, you'd probably assume that, but that's not necessarily true. Maybe they can't breathe because, they have a severe neurologic issue and they can't actually breathe, but the lungs themselves, they're fine. Or maybe it's an issue that their brain is fine, but they actually have bad lungs. Okay, maybe the lungs are good, the brain is good, but the heart's giving out, right? And the heart is then like not pumping adequately. So that's called what disease? Like heart failure. And heart failure leads to what in the lungs? Pulmonary edema, right? So it's not only a lung problem, right? It's a heart problem. So that makes sense. Or you can have like really bad chronic bronchitis, which then leads to eventually COPD, which then it's definitely a lung problem and definitely an airway problem. So they're all attached. So breathing is a spectrum. It's not just like lungs or brain. It can be other things that are causing that issue. That makes sense? Okay. So we got hypoxia and hypoxemia. These are two different things. Hypoxemia, emia meaning blood. Hypoxia in tissues. So a decrease in the pressure of oxygen in the blood. Emia. Hypoxia, abnormal low oxygen content in the tissue or organ. So to call someone hypoxic, they have to have a low what? Which is how you measure how? No. Pulse ox. Right. Now what is a pulse ox? Do I have anything? Okay. I don't know what slide this is. This is slide 34. Okay. So pulse ox uses the differential absorbance of light by oxygenated and non-oxygenated hemoglobin to estimate the oxygen saturation, or as the SaO2. Basically, they got this light, and it goes through your fingernail, and then there's a receiver on the other end, and the degree of how much light is able to go through there has to do with how much oxygenation you have here, or red cell capacity. And then if the more light that penetrates through, the higher your O2 sat, correlates with more red cells. Now, lower the O2 probably means that you have lower red cells. But this is just conduit. I said it has to go to the nail bed. So what do most people have? Yeah, so it won't go through the nail bed. So it's not exactly like, oh, they have a low oxygen saturation, they're hypoxic. Well, I don't know. What's another thing that looks like someone's hypoxic? What color are they? Blue. Yeah, they're like bright pink and like looking at you and talking to you, and their O2 sats is like 70. They have like their nails done. They're probably not hypoxic. It's probably not a good O2 sat reader. So there's that. Then another extreme of that, a non-nail polish situation, is like, oh, maybe they have really bad peripheral arterial disease, right? Like, what's a disease that affects like the fingertips and like Raynaud? Yeah, maybe they have Raynaud. Maybe they can't actually get perfusion there, right? They have poor capillary refill. So always, I'm not saying it's not always true. It's 99% true. That's sad. But like, it's sometimes cannot be true. So you have to look at the whole picture. Don't just treat the number. So here's straight explaining all that. So errors is movement, right? The movement also has something to do with it, nail polish, skin color, vasoconstriction. So high O2 saturation does not mean patient may not be dyspneic or respiratory distress, right? Respiratory distress is an issue with those, 5 things that have to do with the airway, right? So I could be in respiratory distress right now, right? Or I can like grab any of you guys and put you in respiratory distress very easily, right? And how is that? Well, you're out of PA school. You will go into respiratory distress. And it's anxiety and it's neurologic. But there's nothing wrong with your lungs, right? You didn't just get pulmonary edema, right? You didn't just get pneumonia. But you'll be like that's stress, right? Talk to someone. Where's Phil? So but your sats will be fine. I'll put a probe on you. O2 sats 99. You'll be freaking out over there and very much in respiratory distress and having a panic attack, but you'll be satting okay. That's what this is saying. All right. So that's hypoxia. An abnormally low oxygen content of tissue or organ measured by pulse ox. Hypoxemia, you said ABG, which literally stands for arterial blood gas. So that's in the blood. So that is a direct measurement of what's going on in the eye. That's hypoxemia. So a decrease in the partial pressure of oxygen in the blood causes hypoxemia, reduced partial pressure, alveolar hypoventilation, which depends what we're saying, not breathing. Ventilation perfusion mismatch, which can happen with PEs or too much pneumonia. Shunt, intracardiac or intrapulmonary. Now, shunt's an important concept. Well, let's read over again. So, your normal alveolar tissue is processes. You get capillary, gets the deoxygenated blood, gets to the alveolus, gets some oxygen, and onward it goes to get perfused. Oxygenation and perfusion. Lack of perfusion leads to what's the definition of? What's lack of perfusion the definition of? Ischemia, right? So we said ischemic, right? If you're not oxygenating, right? You suffocate someone, choke them, it will stop breathing. Yes. But what color does their face turn? Blue. And their extremities too. They don't show that in the show, right? But everything else gets blue too, because you're not getting distal perfusion. You are ischemic at the other end. Suffocation is an extreme example, but anything that will impair breathing at that point. Okay, now we have reduced. That's so small. So we got reduced perfusion. Okay, so you got deoxygenated blood coming, but something here is impairing this alveoli from having oxygen exchange. What could lead to that? Clot. Okay. Yes. Emphysema, which is a stretched out alveoli, which not so much here. Choking, yes. Pneumonia, right? What if I fill this with crap? Really what pneumonia is. Pulmonary edema, whatever you want to call it. There's crap here. So you cannot have good exchange of O2 like you would over here, because the O2 is, yeah, I wrote O2 there. You see it? Nope, you don't, because there's crap in the way. And that's what pneumonia is. Right back there. All right. So that's pneumonia, like reduced perfusion. Then you got reduced ventilation. So your blood's fine, it's flowing okay, the red cells are there, there's not crap in there, but it's not filling into all it can be, right? It's not as large as it was before. So that will lead to reduced ventilation. You don't need that much oxygen. So the oxygenation will probably be fine. But there's two parts to breathing. One is oxygenation and one is ventilation. Ventilation is described as blowing off CO2. So in this scenario, because your lung volume is not as high, you're not exhaling at the volume that you need, you will then lead to retention of CO2, which is what you get when you have emphysema. So eventually, this will become an oxygenation problem as well. Eventually. But in the beginning, it'll be mostly a ventilation issue. Once it gets to the point where it literally cannot move at all, then it's a problem with both, obviously, because you can't have both. So that's why COPD is like both an oxygen issue and a ventilation issue. And then you have reduced ventilation and perfusion. It's kind of like what this becomes if it's like end-stage COPD, right? That's what we're talking here. It's too small, and now because of how small it is, you have reduced oxygen capacity, and then everything downstream suffers. So to fix the problem here, you just need to get rid of the crap, whether it be it's pulmonary edema. How do you fix pulmonary edema? Diurese them. Get rid of the crap. If it's fluid, and if it's infection, give them antibiotics. Here, how would you fix this? Extra oxygen? No, not steroids, not extra oxygen. No. BiPAP. What's that?
It goes away. Kind of put it in the air.
So we need more volume, right? You need to increase this, right? So with positive pressure ventilation, like a vent or a BiPAP, something that'll increase the size of that, right? And that'll then, as a result, decrease, right? The lungs are an accordion. You guys know what an accordion is? Right? So if I take an accordion and I load it up, and I throw it over to the side, what will it sound like when I throw it over there? Did I play the accordion? But it was a sound made. Yeah. So that's kind of what this is. This is now like the accordion, instead of going like this, I'm going like this now. It'll still make noise, but it's not going to be very long. And then eventually it'll get so bad that it's not going to make noise anymore. You're not even moving it enough now. But like, you don't need much to make the noise. That's what I'm kind of describing between these two. So for here to fix it at first, if I'm, in the first stage and making a little bit of noise, well, why don't you just load it up more? And that's what positive pressure ventilation is. You just got to increase the volume, right? They're still making the noise, it's still making the music. It's just you're not expanding it enough. That's what?
Output changes could be more.
Exactly. But if music or sound is the concept of oxygenation, then you don't need much in the first place. But then if it gets to the point where you're not moving it at all, it's not going to make any sound because you're not moving it at all. That makes sense? A little bit. That's what lungs are. All right. So hypoxemia, you got something called hypoventilation. Means low CO2 exchange. What can lead to that? CNS depression, drug overdose, right? If I told you what I always say, if you have a patient that OD'd on opiates, what do they die from first? Okay, yes, but like what at the atomic level? CO2? Would they die from CO2 or from O2? I heard both. Which one kills them first? Too much CO2 or not enough O2? No. Too much CO2 kills them.
We just learned different.
Except for opiate overdose, they die.
Oxygen is more important.
Yeah, oxygen is more important and would kill you first.
I disagree with that statement. Huh? So hear me out. Hear me out. So like, you guys ever hear those stories of like that kid that's like in the corner, high on dope, and like, fell asleep, family went on vacation or something, they find him like on death's doorstep, and like somehow those guys always make like a miraculous recovery, but like the law-abiding citizens like cough and die. That's how it works that way. The degenerates always live longer. So then, if it was an oxygen issue, right? Maybe we've heard these stories often. He would have a stroke. He would have like brain damage, right? So you don't need much oxygen as a young person. I didn't say old people. A young person, you need like very little oxygen. Like you have to give them very little for them to survive. Like young people, you guys, your body will do whatever it can. It's actually really hard to wait for a young person to die because it takes a long time. I'm talking about like weeks to months. Old people, very quick. Babies, extremely quick. Now, the CO2 is what kills them before anything else because it's that hypoventilation, the lack of breathing, that your CO2 will increase, right? So when you hold your breath for as long as you can, and then you take that gas of air, it's your CO2 that's driving you crazy to breathe, not your O2. Just so you know. So he says, does hypoxia kill? Yeah, hypoxia does kill. But so does hypercapnia, because hypercapnia will lead to what? Acidosis. And that kills incredibly fast. I'll ask him about that. But yeah. I'm also talking ABG. Like if you have pneumonia, you're dying of hypoxia. That's an oxygen issue. If you have asphyxiation, like that's an oxygen issue. That's gonna end perfusion. But if you're just breathing a little bit, like slightly, your CO2 is for opiate overdoses really what kills you because it's suppressing your respiratory drive, and that will impair your ventilation exchange. Anyway, so obesity hypoventilation is called OHS, obesity hypoventilation syndrome, and these are big Pickwickian people or big fat guys that don't actually have good expansion of their lungs. It's back to the accordion scenario. You don't have good expansion because they have this big belly in the way and they can't breathe well. Kind of why like pregnant women have trouble breathing. It's because they have this big belly in the way and they get short of breath quickly. Now it's also short of breath quickly because, they're growing life. And there's a lot of oxygen demand and metabolic demand from that. But it's also because they have a big belly in the way. Like they're like out of breath, just like laying down sometimes. I like them. So have you seen the Pickwickian body habitus? You've heard of this Pickwickian term? No? I'm just saying funny words. Okay. Pickwickian syndrome. They look like this. Just rotund. The Pickwick Papers. So it's like typically your old British man. This is Pickwickian. Oh, that's really small. Man, these are all tiny. But you get the gist. This guy. Yeah. That's Pickwickian. And this guy. Uncle Pumblechook. And another guy. Pickwickian. They're just all belly. It is fun. Obesity hyperventilation syndrome. Look at this guy. So this is the habits. And we all know someone like this, right? And then, they come to the hospital and I'm like, hey man, you have if they have obesity hypoventilation, they probably also have sleep apnea. I'm like, hey man, you have sleep apnea. No, I don't. Yes, you do. Just like you can look at someone like that and you say, you likely have diabetes. And it's like, no, I don't. It's like, I'm pretty sure you do. Because they kind of just go hand in hand. Now, sometimes you'll be surprised. I have a friend that's that big. His A1C is like 5.2. I'm like, I don't know how you do it, man. But I'm like, it's not going to be 5.2 forever. Anyway, so obesity hyperventilation. So because they're all belly, they can't actually have that air exchange. So CO2 is naturally higher in them. So these patients need to sleep with a BiPAP or a CPAP at night because it's a accordion problem, right? It's a volume problem. And when they're sleeping, they're not having that good air exchange because there's not much metabolic demand when you're sleeping. So they only breathe a little bit and then the CO2 climbs. Because expiration is passive, right? Does all make sense? Impaired neural conduction. It's a brain problem. ALS, Guillain-Barré, cervical spine injury, phrenic nerve paralysis. So anything that would affect from the nervous system to respond with breathing. ALS is Lou Gehrig's disease. That's going to be amyotrophic lateral sclerosis, which is going to be like, they just randomly stop breathing and then start breathing again. Guillain-Barré, you guys know Guillain-Barré?
Yes.
Yeah, from which direction?
Bottom up.
Bottom up. Yes. How do you remember that? Guillain-Barré is often confused with myasthenia gravis. Okay, so Guillain-Barré is ground to brain, ascending paralysis. Yes, myasthenia gravis is mind to ground. It's descending paralysis.
Nice.
Yeah, you'll thank me when you learn neuro for that. Phrenic nerve paralysis. Which nerve is the phrenic nerve? C. 3, 4, 5, keep you alive. You have an issue with C3, 4, 5, you have impaired issues with your diaphragm breathing, bad diaphragm, not good for business, right? So that's gonna be all neurological. All of these, there's nothing wrong with your lungs. Your lungs are fine. It's a neurological. That will lead to hypoventilation, which will lead to high CO2, which will lead to acidosis, which will lead to death. Muscular weakness, myasthenia gravis, mind to ground. That's going to be like, they usually can't open their eyes at first, and it goes all the way down. And either one of these, whether it's Guillain-Barré or myasthenia, it's all fun and games till we hit the, not the lungs, the diaphragm, right? Because I don't need your lungs. They're just airbags. I just need them to expand and inspire. That's all I need to do. So there really is the diaphragm that's driving all that. Muscular dystrophy, if you have weakening of your muscles, or severe hypothyroidism, if your metabolic demand is so low, they're not able to achieve it, you'll eventually stop breathing. Or poor chest wall elasticity, whale chest, or really bad like hyposcoliosis, right, which leads like restrictive lung disease. And flail chest. What's flail chest?
It's broken, so it's
Yes, so it's like paradoxical breathing. When you inspire, instead of expanding, it depresses it. Okay. So a V and Q, so V is ventilation, Q is perfusion. Now you should have a match normally of how much you expire and perfuse. But if there's a mismatch in there, well, that's called VQ mismatch. It's an imbalance of blood flow and ventilation. It causes the composition of alveolar gas to vary among the lung regions. Lung regions with low ventilation compared to perfusion will have low alveolar oxygen content and high CO2 content, which makes sense because it's low ventilation. And I've been saying this whole time that ventilation is CO2. So if you have poor ventilation, you'll have more CO2. Okay. Lung regions with high ventilation compared to perfusion will have low CO2 content and high oxygen content, which makes sense because you have more ventilation, you're blowing off more CO2. Yes. Okay. Well, which area of the lungs is more ventilation rich? Which area of the lungs is more ventilation poor? Apex is what? Poor ventilation. So common causes of this could be obstructive lung diseases, pulmonary vascular diseases, or interstitial diseases, which you can get into. TB generally lives in which area of the lungs? Apex. Don't need much oxygen to live. So, VQ, oh, sorry. Shunt. You guys have heard the concept of shunting? So what is shunt? That is shunt. Yes. Area that is let's just say this. You guys know the concept of dead space?
Yeah.
Yeah, so what's dead space? There's dead space and there's shunt. These are two different things. Yes, that's the whole thing. What? Well, they can be both, actually. They both can be both. Let me just go. So, right to left shunt is when blood passes from the right to the left side without being oxygenated. So, what's an example of that?
Atrial septal defect.
Okay, good. Atrial septal defect. That's an example of that. Goes from the right atrium, skips the lungs, and goes right to the left atrium. That blood that skipped, is it oxygenated? No. So once it gets to the left side, it's gonna then go to downstream, and then your tissue is gonna be, hey, this is my red cell, there's no oxygen here. Then it gets no oxygen, and it keeps happening, and that's shunt. So anything that bypasses that, so that you got atrial septal defect, you got ventricular septal defect, right? And conveniently, these things usually cause murmurs. And you can see these on echo. So if you're concerned of a shunt, on a heart shunt, you get an echo. But there's other shunts too. So there's an anatomic shunt, where you get your pulmonary capillary, which then you have your alveolus here, red cell exchange, body da, all good. Well, you may have this thing called an anatomic shunt, which is like this branch of vessel that like skips the whole thing. So some blood will go, but some won't. And you'll have higher amounts of deoxygenated blood in your body. So you may be hypoxemic. But this vessel is bigger than this vessel, we agree? So majority of the blood is getting oxygenated. So this is an example of being hypoxemic, but not hypoxic. Right? Because you're compensating. But then you go into a situation where, like, you really need all the oxygen you can get, like a high output state, like, I don't know, pregnancy or like pneumonia or sepsis, where you need all you can get. And this small amount is screwing it up, and it's not enough. And then you'll be hypoxemic and hypoxic.
But it's not that on its own, it could cause hypoxemia or not.
Yeah, like this on its own does not necessarily need to cause hypoxia. Hypoxemia is in the blood. It goes both ways. It could also be like not enough to detect it in the blood. These only get exposed when you need it. When they land in the hospital, like they're just hypoxic. We can't figure out why. You get the PE study, you do all the stuff, and it's like, what the hell? There's probably something anatomic that's causing it. You're wonderful. Yeah.
Is it all the,
Not all. It's usually like one or two. And yet, yes, it's really hard to diagnose. An easy one is the heartburn. I mean the ASC. It's the same principle. Yeah.
So it's still being ventilated, that alveoli, and it's been.
This area is, but this area is not. So if my fist is blood,
So it doesn't really have a.
it does. If my fist is blood, and I'm going over here, it's probably gonna be like that. So my pinky blood is not gonna be oxygenated, and this one area will. And that's all fine and dandy. So these 4 fingers got O2, and ventilation is also removing CO2, right? When we exhale, we'll get rid of CO2. Pinky blood still is holding all the CO2 we had before and does not get any more O2. And you'll probably be okay. So you need all the blood. And then it's a problem. Because that pinky, if that's gonna be the one that tips you over, it's gonna be an issue.
So how would you say that the pinky is not being treated?
Neither. It's
So how's that missing?
no, it's being perfused.
It is being treated, but it's not being.
Correct. Yes,
Could pneumonia be an example of a right to left shunt? Because the alveolus block
Yes.
is just going.
it could. This is on the next slides. So anatomic shunt when alveolar bypass. Physiologic shunt is when non-ventilated alveoli are perfused. Example in pneumonia or ARDS. Right to left shunts cause extreme VQ mismatch. So right to left, deoxygenated mixing with oxygenated blood.
Earlier when we talked about pneumonia, we were talking about it with reduced perfusion.
Yeah, it's both.
Both.
It's okay. Nothing's in a vacuum. You can't just be like, this is only ventilation and this is only oxygen. And eventually they overlap.
Hmm.
Right?
But wouldn't it be reduced ventilation first? To like the block and the O2, if you start getting that.
Yeah, it could be. Or it could be reduced oxygenation. It depends.
Okay.
Because when you have pneumonia, it's not your entire body. You don't have bilateral pneumonia. You know what I mean? Like you're not gonna, I mean, you could, but like you're not gonna have like all lungs done, dead, right? It's just gonna be like in one area.
Yeah.
So what happens first? Is it the ventilation? Is it the perfusion? It's really hard to know because you have 90% of your other lungs doing the rest of the work. So you don't actually know what it's doing. Because this is like doing good oxygen exchange, good CO2 exchange, and it'll compensate. So it's hard to figure out exactly like, oh no, this area of lung CO2 went down first, not O2, because you can't just get blood from that area of lung. Does that make sense? It only becomes a thing where it's like now it's global. Now it's affecting the whole system. And now we're seeing the changes of, CO2 going up or O2 going down. And depending on which one they do, it depends on their degree of illness. So it's hard, it's kind of both, right? It's hard to say because we cannot look at things in a vacuum. Like, okay, here's the lower lobe. We're going to give this lower lobe pneumonia and we're going to watch. You can't do that because you have everything else going on that's going to say, yeah, it's going to try its hardest to avoid all problems. Does that make sense? So common causes for right to left shunt include atelectasis. What's atelectasis? Collapse of lung. Collapsing on itself. So that area is not going to have oxygen exchange. You can get hypoxic from atelectasis. Diseases with alveolar filling is pneumonia or ARDS. Crap in the lungs, fluid buildup. Right here it is over here. You're going to have reduced exchange of oxygen and CO2. When the movement of oxygen from the alveolus to pulmonary capillary is impaired, you're going to have symptoms of respiratory distress, shortness of breath, rapid breathing, coughing, sweating with diapnesis. That's a diffusion limitation. It's usually a consequence of alveolar or interstitial inflammation and fibrosis, or like interstitial lung disease. So now we're talking about, like, this stuff is just like concepts basically, and we'll get back into them again. They can be confusing. How about a left to right shunt? Problem or not? Not a problem. Right to left shunt problem? Yes. Left to right shunt problem? Not really. So what? You get some oxygenated blood, mixing it with deoxygenated blood, and it goes in the venous system? Big whoop. Sounds like it's all gravy to me. Yeah. Not really. Because it's gonna come, it's a cycle. In a vacuum, yes. Not in a vacuum. So what's the big deal? There isn't much big deal. We actually do something. We actually induce a left to right shunt when we do certain surgeries. It's called bypass. You're literally just putting it on the oxygen in an oxygenator in a machine and shoving it back into the venous system. It literally makes no difference. It's the other way that it's a problem, where you're not getting the oxygenation in the first place, and and you have increased CO2 and putting it back into the side where you need to oxygenate it. So right to left shunt, bad. Left to right shunt, good. Now, confuse you more, or maybe this will help you. I'm not sure. The easiest way to remember a shunt is to think of it as the heart. Don't worry about this random thing over here. Heart is the easiest way to do it. Let me just draw this. Okay. Got heart, RA, RB, A, LV, here, got that guy, pulmonary trunk, central to your lung, right? Over here you got your squiggly, that's your aorta, very tortuous in this scenario. Got your branches, yes. All right, stay with me. So now if you have a shunt, let's talk about VSD, right? Ventricular septal defect. ASD works too, but just for understanding, we'll just do VSD. So you got an opening over here. So now blood that's going to be going over here. It's supposed to go over here, right? And some does, but some of it comes over here. And then that will go into you're getting this crap blood in your fingers, your toes, your lip, anywhere in your body, your brain, right? Not good. Shunt. Right to left. R, L. Yeah? Okay. So now, how do you fix this? Well, just fix the thing that's costing it. Yes? Okay. So that's the easy way to understand shunt. Another way is lump, all the stuff this is talking to you about, right? So now let's go. What actually happened over here, right? This pathway. Let's go into that lung. Well, you got your lungs, right? Trachea. Got your lungs over here, right? Now let's zoom into this more. Then you got your alveoli, right? Over here. And now let's fill this with crap. Yes. And now these are cells. This area is deoxygenated. We'll call that DO. This is oxygenated. Call that ox. Call it deox. So now, what does deox have that it's holding? CO2. Ideally, it would like to give CO2 over here. That CO2 should then travel up here. And that CO2 should then go all the way up the trachea. That CO2 should then come out your mouth. Ideally. And also, O2 should be coming from here. In the environment, into your lungs, to the alveoli. And you should have O2 coming over here. You should. But you don't. Because there's crap there. So you don't get much O2, if at all. So then this cell cannot just wait there for its O2. You know, there's a line. You can't just stop there and wait for oxygen. So it will then go on and go downstream without oxygen. And just like oxygen cannot be given, CO2 couldn't be given either. So these end up with high amounts of CO2 and low amounts of O2. So then when you test that blood, you are hypoxemic. And then distally, you are hypoxic because this is now going to perfuse your brain and your tissues and everything else, except it can't perfuse jack because it doesn't have oxygen. They didn't get oxygen because there was crap here. And this crap here is a mixing of deoxygenated and oxygenated blood, which is what the definition of shunt is. Or you can just remember it this way, which is much easier. And skips all that. Does that make sense? But it's both. Eventually, the CO2 will climb up also. It's not just like one or the other. It's eventually going to be both. Did that help? Yeah. Okay. So, now that's a infiltrative process, right? Like a pneumonia or something else. What is interstitial lung disease? What if your lungs themselves, your lung tissue is just crap? If you just have bad lungs. The whole thing is just garbage. Well, that's what interstitial lung disease is. You just have bad lungs. They're just not good. You have pulmonary fibrosis. You have idiopathic pulmonary fibrosis. You have, cystic fibrosis, just bad lungs. Or you have COPD, which you had good lungs and you made them bad through bad life choices. So to diagnose that, you do one of these things. What's this guy doing? Spirometry, right? So you have to weigh. So it's a common office test. It measures how much you inhale, how much you exhale, and how fast you exhale. That's your FEV over FEV1, FVC. Ring a bell?
Yeah.
Okay. PTSD.
Yeah.
You guys seen this chart?
Yes.
Beautiful chart. What class is this from? The 0?
Yeah.
So, are you guys all experts in this?
No.
Yeah. It really is.
It's kind of out like.
Oh, this is really important. Actually. Yeah. Let's take a 5-minute break. And we'll come back. Come back like at 9. 9:12. Yeah.
Is there any way that you'd be able to explain that first process again, just like, we get like the shunt?
Yes.
I unfortunately wasn't able to say this out.
Okay, I'm gonna get a coffee.
That's fine, yeah, that's fine. The whole act. Oh my god. That's not my way to school. And then I'll see the area where I would go, it's like, like, oh, that is what it is. And so I had to get this speed limit. Like 5 minutes. 5 minutes. So then I'm like, and then life doesn't but there's like not that many people and it's like, you know, like 39. Like, I really feel bad. And I'm like, I was like, what? And then I was like, no, like, I'm not gonna even save myself. Nothing like that. Like, and I was like, oh, that might be, yeah, like, it's not like I didn't have this. I don't even know, I think it's like, right, I was like, no way, am I gonna close your house? Yeah. I was so stressed because here I'm going to stop. I don't know. Every time you act today, you're just like shaking. And I'm like, calls me and he's like, are you alive? You're like, it's like, I was like, really good. That was like, it's in the morning. I'm walking the one. Yeah, I would go all that, like, if I have any chance, I think that was being stressed. Oh my gosh, yeah. And it's that. Yeah, well, I like super old. It's like, it's not a lot of questions. Yeah, like, for that, that's like sour water. I like it. That's like, I think 8% of your grade. Yeah, like that. A lot of grade. What? 20. But that will. So then I started to get a bit, and I was another like, and so we're gonna get it, you know. I just think about it. Sweet. It's when it's funny and there's like a lot of. Yeah. I don't know why I suppose I should like extra hard. I don't know why, I just keep on mixing this up. It's just like overexposure, more color, more lighter, more, and then black. I never remember. I would be actually really show you. Send this to me.
Yeah.
That was so, I put it into my head, 2 years ago, like towards the bottom, but you know, I feel like everyone really likes it. No, it's just, I really don't totally get it. Yeah, I don't know, I really it's like, working, like, I don't know, so, that, or just a little, yeah, actually, I'm nervous, but I mean, I did study, so. To be honest, I had my friend from last semester that was there. What? Right? You know, and they're like,
Oh, you would know reserve. Honestly, pick a random picture and tell me to believe it. Right. Yeah. Like his last one. You need to like, I need to get official.
I'm really, I don't know, it's like, yeah, but I feel like, also I can't, yeah.
That's like- I gotta start laughing.
It's not. Still like what it says. I don't, it's like a new, yeah, yeah. I'll just.
Let's resume.
I teach I honestly need to go.
Yeah, that is better. You would expect, you would have actually. So it's better was fine, you would.
Let's resume.
Yeah, I do.
So you got your spirometry curve over here. These all have different functions. Total lung capacity is over here. Never actually truly achieved total lung capacity, or never actually able to expire all of it. You always have a little residual left. And you have your vital capacity, which is generally what you use. You have something over here called tidal volume. That's the breathing you got to do just to, this. It's the breathing you do when you're sleeping. When you yawn, doing that extra breath, that's really you're trying to use your vital capacity, right? You never really reach total lung capacity. So your tidal volume is just the breathing you got to do just to get your lungs, your normal level of VQ fuel is normally 6 to 8 cc's per kg. You don't know that. But why am I harping on tidal volume? Is because this is the setting you actually set on a ventilator. Tidal volume. We're not going to give them, right? If I have someone on a vent, all right, and they weigh, I don't know, 70 kg. I don't know jack about them. I don't know what their lungs look like. I don't know anything. But they weren't breathing in the field and we intubated them. We have to connect them to the vent. So you just weigh them and put them at 6 to 8 cc's per kg. So be 70 on the lower end, called 6. 70 times 6 is 420. Your tidal volume can be 420. And that's what you set it at, because it's based on their weight. So that 420 mLs is what's going to be inspired and expired every time if the machine breathes for them. That's called set volume. Volume control. And there's something called, we don't breathe that way naturally. We don't take the same volume with every breath. We vary how much volume. Gotta take a short breath. Let's take a deep breath. That decision of how much to breathe is all up here. Your brain's controlling that. So that's called pressure. You're varying your degree of volume. So that's tidal volume and just the volume you need to have normal number. So then you got your FEV1, FVC, and FEV. So what this is in the spirometry is how much you inhale, how much you exhale, and how fast you can do it. Someone who has COPD would go, that's the best they got, because they can't forcefully expire efficiently because they have air trapping and they can't get it out. So FVC is functional vital capacity. That's this. That's the most you can do. That last breath, that residual volume, that's what goes away when you die. That last amount, that's what that is. You'll never achieve it alive. Functional vital capacity is how much you're gonna hold your breath and blow everything out. You'll never achieve that last amount. So that's what FVC is. That's sure. So functional vital capacity, that's what that is. Now, how much you exhaled over how long it took. Normal, you should take a deep breath in and blow. Normal. Obstructive lung disease, take a deep breath in, blow it out. Restrictive lung disease, like scoliosis. This is a problem getting the air in. Take a deep breath in. Out. Comes out fine. Going in is the problem. So that's the difference between obstructive and restrictive. Here's some big ass chart of all that stuff. And there, you guys know gold criteria? No. You're gonna learn gold criteria. It's like COPD criteria. It goes real hard on FEV1 over FVC and all that stuff. I'm not gonna go as hard, but Weber's gonna go hard with that. Yeah.
Someone who goes to like say cardiac arrest, they like immediately lose their residual volume, or is that something?
I don't know the answer to that. It's a good question. I'm assuming they do, because they're dead. This depends on how they go into cardiac arrest, right? They're just like here. Probably. But if they go into cardiac arrest while like connected to the ventilator, I don't think so. But even if like they lose it, as soon as you ventilate them, like it's back. Okay, so spirometry is pulmonary physiology, forced expired vital capacity, or FVC1. Volume of air blown out forcibly in 1 second. That's where the one comes from. A function of large airwaves dependent on body size. So I told you it's weight based for the vital capacity. Total volume of force expired air. So the ratio is FEV1, how much you blow out in 1 second, over how much you got inside of you. Then there's the DLCO, which is absorption of carbon monoxide in one breath, gas exchange. We don't normally measure that. So obstructive lung disease. When we think of obstructive, what disease I want you to think of? It's COPD. It's literally. So forced expired volume in 1 second is usually decreased. Air trapping is a problem. Forced vital capacity, it might be normal or decreased, but your FEV1 over FVC has 2 apples down. It's really low. But because it's an air, I want you to think COPD, obstructive, air trapping. Residual volume is going to be higher. They're going to have larger lungs. Their lungs are going to be stretched out more. And when I say air trapping, I'm not saying oxygen trapping. I'm saying air trapping. So that air is going to contain what? CO2. It's going to be, they're going to have high amounts of CO2 all the time. Here's a normal lung. Here's an obstructed lung. It's just bigger. Restrictive. The disease I want you to think about for restrictive lung disease is scoliosis. Now, why? That's the easiest one I can think of. It's weird. Yeah, because they're little, if you're saying a really bad. Everyone stand up. So I hope you understand. Bend over at the waist, literally, and take a deep breath as much as you can. That hurts. Yeah, imagine breathing like that your whole life. Okay, so you can't get the air in, but going out is fine. So that's restrictive lung disease. So really bad kyphoscoliosis, that's what they develop. So your normal lung is bigger, and in a restricted lung, it's smaller their whole life because they can't properly breathe it enough. But there's nothing wrong with air escaping. It's air going in. If you're bent over enough, it's hard to get air in that way. Yeah.
So why, like, after you like run, is your first instinct to like to take a breath?
So your legs are tired. Guess so. I don't know as much. But is this like the most comfortable way to like breathe after you're done running? Because you have to expand everything. You also want to drop dead and reduce activity as much as possible. Maybe it's your brain trying to get to the ground saying lay down. Like you're dead. Like stop.
What? So we like not touching.
No, because your whole lung is now like, if you don't use it, you lose it, and like, it's like, starts to like reduce in size, but this isn't just like one breath, it's like.
So compared to normal.
Yeah, this is a normal lung, this is small, it's just smaller. And obstructive, this is a normal lung, this is a abnormal, it's much bigger. So distinctive clinical and physiological features define obstructive lung disease, which is COPD mostly. Your total lung capacity and functional vital capacity are normal or increased, decreased FEV1, that 1 second you can't do it. And another way to understand that faster, right? If you want to have an exercise, and you should be doing these weird things like on your exams. Like we tried that, and like it's pretty much what it is. So like for obstructive lung disease, are your airways small or your airways narrow? No, I'm sorry, those are the same thing. Are your airways small or your airways large? Large, right? So now, purse your lips and try to blow your air out as fast as you can. Fast, right? Now open your mouth, don't purse your lips, try to blow your air out. You can't do it. You look stupid, and you can't put force behind it. It can't come out as fast. That's literally what COPD is. Your lungs are just big, your airway is just bigger, so you can't get the air out fast enough. But if it was narrower, it goes much further. That's basically what that is. So that's why you have a decreased FEV1. Restrictive lung disease, you have a decreased functional vital capacity because your lungs are smaller and you're not using it as much. But your FEV1 FVC ratio is normal, right? It's a ratio, right? When I'm talking about the whole lung size, it's the ratio in proportion of how much you breathed in versus how fast you breathed out. If you breathed in a small amount, but you breathed out it quickly, well, that's okay to a degree. And you have decreased DLCO. Pulse ox, you went over already. Blood gases, you're learning now. This is a true measurement of what's going on in the blood. You get the pH. So now this is organized, this table, in importance. The most important thing is your pH. Yes, the most important thing is the pH. Okay. Now, your PCO2 is direct relation. What did he say?
He said,
Oh, okay. All right. No. Let me finish. These are two different pathways here completely. One's acid base and one's oxygenation. Those are two different things.
Yes.
You cannot say that one is more. What's more important, your lungs or your heart? They're both important. You can't just pick one. So it depends on which one you want to live without. Lungs or heart? You're not getting a replacement.
Oh, I was gonna say let's get it.
You're not getting a replacement. Which one you want to live without? It doesn't make sense. I need both. Your dad's got a heart too.
Yeah.
The point I'm making is it's an impossible situation. You can't just pick one and say, oh, it's not a vacuum. Again, these are all combined. So your pH is your most important as far as acid base is concerned. So pH in CO2, this does not apply to pH. This applies to pH. This does not apply to pH. So these two are separate. That's a separate category. These are also separate. So like as far as your blood gas is concerned, if your O2 is low, fixing that is like a separate thing. Fixing CO2 is a separate thing. These are two different pathways of how to fix it. You cannot fix one. There's not one fix for all. That's why they're separate. So now the pH is the most important thing in the blood gas because acidosis will kill you very quickly. So if your PCO2, so like there's like when you do your EMR and stuff, like certain numbers in the labs will be red. Everyone wants to fix numbers that are red because they assume that that needs to be fixed. And it usually does. But let's say your CO2 is high. Let's say it's like 65. Your pH will then be what? Low. Yeah, so that's acidosis. Yes? Okay. Now let's say your PCO2, another name for it, is like 5. So it'll be red. Means you're probably breathing how PCO2 is 5. Incredibly fast. You're just really tachypnic. Your pH will be what? Well, it depends. You would assume it would be alkalotic. But what if I told you that your pH is 7.40 on the money normal, but your PCO2 is 5? Are you gonna make any changes?
Well, your body's compensating. Is it with the compensation?
You tell me. Is pH 7.4? So are you gonna make any changes? Don't rock the boat. And then someone's gonna say, hey, PCO2 is 5. I can give you this critical value. Okay. Do you want me to decrease the support we're giving them? And the answer is no. So, but the PCO2 is 5. My answer is, who cares? Because pH is all that matters. Now, if your PCO2 is 5 and your pH is like 7.7, that's a different story, right? That's now inducing alkalosis. That's different. But if your pH is normal, do not rock the boat. You should treat the underlying cause, but you don't want to rock the boat. It's normal. Figure out how they look. If they're compensating, they're not going to imminently die because cardiac arrest is acidosis. They are not acidotic right now. They may become acidotic very quickly, but whatever they're doing to blow all that off, it's working. Okay? This is how DKA patients present. You never intubate a DKA patient because they're breathing very fast, and my machine can only breathe as fast as 35. It cannot breathe faster than that. If they have a PCO2 of 5 and they're young, they're probably breathing like 45. Now, not ideal. Definitely not good. But what I say, young people can live for a long time. So if I put them on the machine, I'm killing them because I can't do as good as they're doing. So you always, that's why pH is the most important number. PCO2 is a direct correlate of this. Bicarb, this bicarb on a blood gas is not a real bicarb. This is a calculated bicarb using like Henderson Hasselbalch. So it's not a real bicarb. A real bicarb is on your chemistry under CO2. That's your serum bicarb. Now, is it crap? No, it's not crap, but it's not real. So it's in the ballpark. So am I going to take it seriously? Yes. Am I going to question it often? Yes. If it's very low, is it likely to be fake? Probably not. Is it 20 or 24? I probably need a real one. You understand what I'm saying? It's not like, oh, it's 5, which is like severe acidosis. I'm gonna be, nah, it's probably like 20 on the serum. I'm like, no, it's not that off. That's acid base. These two is oxygenation. That's a separate issue. That you fix with more oxygen. And that's it. This you fix with changing the respiratory rate, changing the ventilation. This you fix with oxygen or P. These are two different. So pH, PCO2 is ventilation. PO2 and SAT is perfusion. These are two different concepts that all together make up the same thing. Now, if I suffocate someone and they stop breathing, PO2 will be low. SAT will also be low. CO2 will be high and pH will be low. So there's mixed pictures. It's not just like, oh, one or the other. You can die of both or you can get compromised by both. But I think the most important value is the pH because it's the most complicated and confusing to understand. PO2, I can just say if it's low, increase it. That's it. Is it important? Sure. Is it the most important? Yeah, I guess. But like it's also like common sense. Like, duh, yeah, fix it. Increase the oxygen. All you got to do is do that and say, okay, done. And you walk away. The pH is like much more complicated. Is it a kidney problem? Is it a respiratory problem? Is it all respiratory? Is it mixed acidosis, alkalosis? What's going on? Are they vomiting a lot? Are they losing CO2? I mean, chloride, it's more complicated. That's all that stuff says. So your typical respiratory acidosis is going to be, so acidosis means what? Low pH. Respiratory or metabolic, if it's respiratory, what has to be high? CO2. If it's metabolic, what has to be low? That's pretty much that. So metabolic acidosis, low pH, low bicarb. Respiratory acidosis, low pH, high CO2. Your bicarb can be normal, but you'd hope it eventually would increase. Respiratory alkalosis is going to be high pH and your CO2 is going to be low. So who gets respiratory alkalosis? That person that I put into respiratory distress, if I grab one of you guys, say you're at a PA school, if you get anxiety, you just start breathing fast. Nothing wrong with your lungs. You're just breathing all your CO2 off because you're hyperventilating. So they used to say, hey, breathe into this paper bag so that whatever you exhale, you are re-inhaling CO2. That was the theory of that. To combat that. We don't recommend that anymore. I don't know whoever recommended that. Metabolic alkalosis, you're gonna have high pH and a high bicarb. This is kind of hard to get. Usually drugs do this to you. Not like bad drugs, like pharmacology. So you guys did a podcast with Mike, right?
Yeah.
Alright, so I'm not gonna go hard on these. Alright. I can spend like 2 hours talking about these. Blood gases are very fun. Okay. Asthma. So you get your normal airway over here, and these are your asthmatic airways. Your asthma is a three-headed monster. You got what again? Yeah. Yeah. Spasm, bronchospasm, right? Three-headed monster. Inflamed airways, mucus production, bronchospasm. So here's a normal airway, here's an asthmatic airway, naturally more narrow. And then a asthma exacerbation, you're gonna have narrowed, thickening, and inflamed areas all around. The term, the lung sound you get during an asthma attack is what? Wheezing. In Bates, wheezing is called a musical note. Yes. Musical note is like whistling. What it sounds like. To whistle, you must purse your lips in constriction, lick your lips, fluid, and blow in inflammation, if you will. So that's what it sounds like when they're doing. So you can't, if you don't have those three concepts, you can't whistle. You can't whistle with dry lips. It doesn't work. So chronic inflammatory disorder characterized by hyperresponsive airways, episodic reversible bronchoconstriction. Episodic reversibles. This is a type of sensitivity reaction such as the type 1, right? Allergic. Bronchi and terminal bronchial. So asthma disease is a disease of atopy, atopic disease, right? Airway remodeling and air trapping. So your normal airway looks like this, and an airway in a person with asthma will look like this. Swelling, tight muscles, and mucus. So there's intrinsic and extrinsic atopy. 70% are extrinsic, meaning the environment is what triggers it. IgE responds to inhaled antigen. Certain things will trigger the asthma. Intrinsic is non-atopic, non-immune mechanism like cold-induced, viral, or asthma. Atopic type is a hypersensitivity reaction. Type 1, which we talked about. The allergen binds to IgE on mast cells. Remember, those are in the first slide at the alveoli. CD4 helper cells release interleukin 4, interleukin 5, and we go down the whole inflammatory cascade. Yes. Remember these guys? Eosinophils, your main guy here. All right, there's a bunch of stuff here.
You drawing?
What?
What was your drawing?
It's similar, yes. But this is now in regards to, my drawing was in regards to infection. This is the same thing, except we're talking about like mast cell sensitization, other stuff. So it's a little bit more complicated, and I don't want to get into this right now. Sorry about. But now the stepwise mechanism of asthma treatment. So it used to be SABA, LABA, ICS, but now they changed it. Now I don't know what they're teaching you now for the boards.
Oh.
It's still SABA, LABA, ICS. All right, cool. That's the easier way to remember it. Now they start with LABA and SABA. No, don't know this. Like, don't get confused.
How does that combo?
Huh?
How does that combo?
Oh, trilogy?
Trilogy.
Yeah, it's like a combo of like Saba, lama, and ICS. But, no, actually it's, leukotriene. Yeah. It's a lava, llama, and ICS, it's not a Saba. You know what Saba is? You guys know these terms mean, right? I'm not just talking like phrase words. Talwar didn't do with you? Oh, you're gonna have Talwar though, right?
Yeah.
Yeah, all you gotta know from Talwar's class is Saba, Laba, yes. This doesn't sound right now, but when you have him, you will talk. So Saba is short-acting beta agonist. This is albuterol. This is going to be short-acting, which is going to be a rescue medication whenever you have the symptoms of any respiratory distress, of wheezing, vasoconstriction, or it doesn't really have a great effect on mucus production. So 2 out of the 3 of the asthma exacerbation monster. So that's albuterol. Short acting. If someone is diagnosed with just a little bit of asthma, you're gonna give them a Saba and you're gonna say, here you go, sir, here's your albuterol. And I only want you to use this if you really need to. Do not use it regularly. It's not supposed to be a long-term medication. And then you have a patient that says, hey, I have a little short of breath, I'm gonna use that. Wow, that felt really great. And then tomorrow, I'm gonna use that again. And then I'm gonna use that again. And then I say, I'm gonna see you in 4 weeks. And you come back in 4 weeks and I say, can I see your albuterol? Okay, yeah, you're out. I gave you enough for a month. This should only be for rescue. So the fact that you use all of this in a month tells me that you are more symptomatic than you appear. So this is no longer your treatment. I have to give you a long-acting beta agonist, a LABA, that you will now use, like formoterol, and you will use that every single morning. And that is not going to save you if you're acutely short of breath. This will only maintain you. But I still am going to give you another prescription for albuterol, and you're still going to use that for rescue. And I ideally would like you to use your albuterol less because you will need less rescuing because I put you on a longer term regimen. We are clear? Okay. They go, they come back. All right. So you still went through your albuterol and you use your long acting. So now you need more. Now I'm going to give you a long acting and I'm going to give you an inhaled corticosteroid, which should help reduce the inflammatory process of your obstructive disease, which is kind of what asthma is. And then I'm still going to give you albuterol because I still want you to be rescued. And then I'm going to come, I want to see you in 2 weeks. I'm going to come back and I'm going to say, all right, let me see your albuterol. Say, oh, actually, you have a lot of albuterol left here. So this therapy is working for you. We're going to stick with this therapy and we can follow up in 6 months. Okay, cool. And then they come back in 6 months. Hey, can I see albuterol? Damn, you didn't even use albuterol at all. That means it's really working for you. Great. Or are they going to come back saying, hey, I need to refill my albuterol like 2 weeks after they left? What the hell happened? Come back in. I have to test you again. Do another spirometry, check the FEV1 over FBC. And then it's like, okay, now I got to add like sertraline, or not sertraline, singular. I got to add singular. And then you got to, which is a a llama. What's the muscarinic thing? And then you can so on and so forth. So this is how you treat asthma, and this is what this scenario I'm describing is the gold criteria of like what you give. That was the old way. This is the new way. It's annoying. So it's still Saba. Like if you're just a little bit symptomatic, like maybe someone here is like, oh, I think I have asthma. Like, I had asthma. They gave me an inhaler. I never followed up again. I haven't had an attack in like a long time. That's this person. Right? Like I have this. That's me. But like persistent asthma is like continuous. So that's like preferred is a low. They start with inhaled corticosteroid off the jump, and then they give them like all these other things. So don't worry about this. No, yeah, the way gold criteria. That's the way you gotta know. Whatever they're teaching you, because this is confusing, and they just changed this like 2 years ago. It's very annoying. You gotta breathe in a whole other thing. It's a long time. Wait, what?
2 years is not, it's not right now. Years ago.
You think that's a long time ago?
Not long time.
In medicine, this is like yesterday.
That's a change of curriculum.
No, you can't change the curriculum because then the boards have to change it. You don't know what the boards are teaching. They have to tell you we're doing this guidelines. Like when I teach you blood pressure, like JNC 8, it's a JNC 9 now. In 2024 in medicine is like 2 hours ago. It's very, very quick.
Why'd you change it though?
Because a bunch of people got together and started to make it more complicated. I don't know. It was working fine. They gotta stay relevant. I don't know. All right, so asthma symptoms. So you got cough, nocturnal cough, right? Asthma is one of those things. Wheezing, shortness of breath, chest tightness, sputum production, and decreased exercise tolerance. There's a little kid with his albuterol. Then you have COPD. So that's a combination of emphysema and chronic bronchitis. Fourth leading cause of death in the US. Often they coexist. Emphysema and chronic bronchitis, you're going to have air trapping, breaking down of your air sacs, mucus-filled airways, copious mucus production is a hallmark of COPD. It's irreversible. So if you have pure chronic bronchitis, you have large airways, trachea, bronchi, mucus hypersecretion, inflammatory, that's chronic bronchitis. Your small airways, your bronchioles, you're going to have airway obstruction or chronic bronchiolitis. And emphysema will have acinus alveolar duct that are less elastic and more air trapping, and that's emphysema. Combine the two, and you got chronic obstructive pulmonary disease. Yes. These often have air trapping and blebs. They're prone to spontaneous pneumothorax. So permanent increase in the size of the air spaces distal to the terminal bronchiole. They are hyperinflated. They are air trapped. They have more CO2. Destruction of the alveolar walls. We use the term dilatation. That's due to loss of the alveolar walls or tissue destruction. Less elastic, excess function of elastase from smoking injury. Also, if you have alpha-1 antitrypsin, you can also end up with emphysema. Appears as holes in the lung tissue, and you have loss of parenchyma without fibrosis. What is parenchyma?
Lung tissue.
Just tissue. Yeah. Without fibrosis. Fibrosis is different. Impairs respiratory function, diminished alveolar surface area for gas exchange, loss of support of smaller airways. Hallmark is loss of elastic recoil, damage from elastases, leading to tendency to collapse with expiration. Here is good lung. Here is bad lung. People with emphysema and COPD generally have air trapping, so their CO2 will generally be higher. Here's what it looks like. These, see how big these holes are? They shouldn't be that big. You shouldn't be able to see any holes. Oh, yeah, protease and antiprotease theory. All right. So this is basically like the smoking is like the genetic versus the environmental theory. So elastic tissue is damaged by elastases, which is produced by neutrophils and activators. Alpha-1 antitrypsin acts as an anti-elastase. I hammered that into you guys. You guys get that one. Imbalance in the system predisposes to destruction of the alveoli walls. Yes. Then you have the tobacco theory, which is increased neutrophils and macrophages in the lungs, inhibits the alpha-1 antitrypsin, and contains lots of free radicals. So then, like, this doesn't affect everyone. So I can get 10 people, give them a pack of Marlboros at 16, and they smoke their whole life. And like 8 of them will probably die of COPD. And 2 of them will be like, I live a normal life, and they'll be curious how they're alive for that long. And these are the old people that you see walking around that are like 70 or 80 and just like smoking, like they smell like a pack of Marlboros and they just smoke cigarettes all the time, and like they live a normal life. Not everybody that smokes ends up with COPD, but majority of them do. And it's genetics, which comes down to this theory. Some of them have more protective, like proteinases, antiproteinases and such. So yes. Sometimes it's hard educating these patients in the office about that. Well, my grandfather smokes a cigar every day and he's lived to 95. What do you even say to that? So this is the alpha-1 antitrypsin deficiency. Is codominant genetics. Blah blah blah. Basically, your liver has to do with the alpha-1 antitrypsin, and then that leads to the lack of protective proteases from lungs. So you'll end up with emphysema without ever having smoked a cigarette. Fun fact: I don't want you thinking that alpha-1 antitrypsin is just like a COPD thing. Like you end up with liver failure. Also. Then you have pan-acinar emphysema, which is like really bad emphysema. Now look at this one. There's literally dust in the wind. Like it's just like completely eroded. What are these? Blebs. These are blebs in the lung. So this is a living patient. This is a freshly removed lung. How can you tell? This one's red, bloody. This one's moved. These are blebs. So these spontaneously rupture by coughing the wrong way, sneezing, anything that'll increase intrathoracic pressure, and then you now have air in the thoracic cavity. So this is how you get a spontaneous pneumothorax if you have emphysema, because the bubble literally pops. Sometimes we're afraid to intubate these patients because as soon as we put in that tube, what do? We expand and we're afraid of something popping. So we sometimes say, hey, this guy has really, we call it bullous emphysema. This guy has bad bullous emphysema. If all of a sudden he starts crapping out, he probably has a pneumo. Get a stat x-ray and assess that way. Or like if he cardiac arrests, his likely cause is a pneumothorax. And we see it all the time. We're like, oh, patient just like all of a sudden it's like fine, and then just everything just starts beeping and like what's going on? And pneumothorax is kind of hard to like. Yeah, we hammer it into you guys, but like it's like not easy to find. Like it's not like the first thing like, oh yeah, this is what it is. Like it's you have to get an x-ray, you have to listen for breath sounds, you have to get an ultrasound, like it's hard. And no one's gonna be like, yep, pneumo. But if you have someone like this, it's probably a pneumo more than anything, because like you see this on CT. And here's some guys smoking. Let's see. Okay. So decreased PaO2 leads to your clinical. They use the term pink puffer and blue bloater to describe emphysema and COPD. They say not to use that anymore, but I think it works well. So they'll be dyspneic and have increased respiratory rate. So emphysema patients will be usually pretty skinny. They'll have an increased hypercarbic drive, so they'll have more CO2 retention. They may be barrel chested because of the air trapping. They are prone to infective exacerbations, meaning that if they have the cold or like a pneumonia, it'll really do them in. Which is why these patients who have, so this is what a core morbidity is, right? So this is someone that you get vaccinated for like COVID, right? This is someone that you get vaccinated for like the flu, regardless of age, because if you get sick a little bit, like you're just going to go into a downward spiral. So this is what we mean by core morbidity. So they should get like the pneumovax, like the strep vaccine earlier. Pulmonary vasoconstriction, pulmonary hypertension is common as well, and death by respiratory failure or heart failure, which is cor pulmonale, which you'll learn out Dr. Talwar. Pulmonary hypertension, great topic. Talk about that next week. Chronic bronchitis and more like your blue bloaters and like your heavier set guy, kind of Pickwickian, barrel chested. Productive cough with sputum, 3 days, 3 months, 2 years, hypersecretion, smoking and pollution was the cause of this. This is non-reversible obstruction. Chronic irritation, defensive increases in mucus production. You have hypertrophy, hyperplasia, and metaplasia of epithelial cells. Metaplasia, not good. Usually the risk of cancer element here. Increased sputum production and tendency to infection. But just like emphysema, these patients should get prophylaxis and treated with vaccines, and they're also prone to infections. And the goblet cell is the cell responsible for the copious mucus. Goblet cells. Here's your blue bloater, bigger guy, big belly, Pickwickian type picture. Like, you know, like this guy has sleep apnea. Like, even if I didn't, you just did it. Like this is that's what it's like, just like inspection. Like you just look at him like, yeah, this guy has this. You just automatically know. Prominent cough and production of sputum, they'll be bronchorous, outflow obstruction, hypoxia, and cyanosis. They can't get the air out. It's like, you know, interesting, right? It's like I keep telling you that obstructive is going to be air trapping, right? And air trapping is going to be higher CO2. Why is he blue? Well, it's blue because there's reduced oxygenation as well. It's both, but it's mostly CO2 at first. But this is a perfect example of they're all attached. They're combined. Pulmonary hypertension and cardiac failure. fairly poor pulmonale as well, and they are prone to infections. There's some new interventions on how to fix this, right? It's like irreversible. But that area of lung that's dilated, air trapping. So you can just cut that lung out and keep the good parts. Might actually improve that. Or you can shove something in there and just block it off. So they still have the tissue, but there's no air going to it. So you've increased your air exchange. Pretty interesting stuff. Lung volume reduction surgery. You can live with one lung. You don't need two lungs. So in turn, you can then live with portions of the lung. Now, interestingly, they're removing the apices, which is usually where the CO2 is highest anyway. Bronchiectasis. This is going to be, yeah.
For blocking it off, how would that not cause like necrosis? Tissue dying?
Yes. Because you're blocking off the airway. You're not blocking off the blood flow. There's still vessels there. Okay, bronchiectasis, permanent dilation of the bronchi and bronchioles, destruction of the muscle and elastic tissue. This is kind of like your really bad chronic infection pneumonias. You're going to have like dilated airways just from crap being in there all the time. A lot of junk and a lot of secretions there. Those secretions are more prone to like more aggressive infections like Pseudomonas and such. So it can be a cause and a consequence of infection, or a symptom of that can be infection. It can lead to obstruction as well. Tumors, foreign bodies can cause it. Impaction of mucus. The disease that you want to think about when we talk about bronchiectasis is cystic fibrosis. These are going to be generally children. Why are there no adults with cystic fibrosis? Yeah, they all die in childhood. Sad. So generally children here are going to have cystic fibrosis, but these are sickly kids, very sick, because, well, what do they do to get cystic fibrosis? They're born with it because of what? CTFR gene, right? And that gene is going to lead to the mutation of them having this bronchiectatic disease. So they're more prone to nasty bugs. What are nasty bugs? Pseudomonas, Staph aureus. So these are chronically sick, and all they have is mucus and mucus and mucus, and it's like the downward spiral. So they have to wear like these vests that'll percuss them. So how do you fix this? How do you diagnose it? It's a board question. A chloride sweat test. They have chloride in their sweat, and they can. You guys have heard of that chloride sweat test?
Yeah.
That's a way to diagnose it. Genetic testing, another way to diagnose it. So how do you fix it? Well, what if I told you you can cure someone with cystic fibrosis? Give them a lung transplant. The only way. Cystic fibrosis or disorder can cause lung congestion, infection of malabsorption, and affects the pancreas as well. You can get pancreatitis with cystic fibrosis. I'll just finish bronchiectasis will be done. So chronic inflammation damages and weakens the walls, leads to obstruction and infection. What the concept of obstruction is not like obstructive lung disease. It's obstruction from mucus impaction causing like a mucus plug, and the mucus plug is the most common cause of what? Atelectasis, which then can lead to collapse of the lung. Then you'll have impaired perfusion as well. Severe persistent cough, mucopurulent sputum, talking like hacking, tenacious sputum, they call it. Chronic infections, they get abscesses as well. Abscess, always bad. Lung abscess, extremely bad. Like these patients are not just like a little sick. They're not just like, they're just like, they're like dying, and it's needs to be addressed surgically. They may have hemoptysis and they'll have club nails. So infection leads to inflammation, leads to airway obstruction, leads to bronchiectasis, and unfortunately, like I said, it's a cycle. It just keeps happening. It's a thickened wall, there's more mucus, and just chronic infections. All right, we got to do about half.